governments and community, because we know that the right to health can only be conferred by governments. And it's really important that civil society has a real part in kind of demanding those rights as well. Yeah, so, you know, I've been at Partners in Health about 5 years now, and kind of prior to that, you know, was working in Indigenous health in back home in Australia, and in the Pacific region as well, as Jason just mentioned. I wanted to start off with a quote to kind of provoke a bit of discussion for later. This is from the editor of The Lancet. So it's probably the most famous medical journal in the world. Many of you, I'm sure, have heard it. This is something he said last year about global health. He said, quote, "The more I see global health leaders congratulate and applaud one another, the more I think that global health is a vast international conspiracy to maintain the political and economic status quo." So just to provoke, and I'd love to hear kind of your thoughts about this later, but just seems like a decent starting point for getting into this discussion. And I mean, just as we start, I just want to think like, you know, what actually is global health? What do we mean by global health? I think like, despite the name, which, you know, would imply kind of universality, actually it commonly refers really to ever outside wealthy countries, basically. It refers to often what's referred to as the global south. So anything in the global north, in North America and Europe, in Japan, Australia, New Zealand, etc., is really considered the global north. So basically what this means is that there's an implicit understanding that is deeply colonial and really, you know, extractive in nature about between like the relationship between the global north and the global south. So basically what I'm saying here is like the roots and the legacy of global health are deeply, deeply colonial. And so, you know, of course, it's the ravages and the legacy, you know, of the projects of colonialism, of imperialism, of racial capitalism and neoliberalism, and, you know, really all other forms of white supremacy that have caused this incredible, massive global health inequities that we see today. Inequities that, you know, are reflected by statistics such as like there being difference in life expectancy of 35 years between some wealthy countries and some impoverished countries. And countries that have been impoverished, not by accident, of course. So, you know, I think with this in mind, it's probably worth keeping in mind that, you know, each time we say global health, we should make a point of maybe also saying equity, because global health equity is probably a better term because it makes the ultimate objective clear. And, you know, which is really the case when it comes to global health funding. The objectives often aren't clear. And also it makes it universal. It applies to every country and community. It really, it's not acceptable that we think about global health in terms of disparities between countries, but not within countries often. And so global health equity should apply to every person and every individual, because we're talking about a right to health, which, you know, everyone holds that right. So, and of course, you know, health disparities of 35-year difference is seen not only between countries, but is seen within this country we sit in today, between communities and between cities in the US, of course. So, I mean, what's the like major problem or common problem with the status quo of global health funding? I think like, well, where to start really is one question. And I want to hear from all you guys, but really want to hear about your thoughts on this. But of course, like, it's so deeply paternalistic and colonial that it can render itself, you know, very ineffective, inefficient, to the point where also like some of its objectives are just completely misaligned with the local priorities of many places. So of course it's grounded in charity, not in justice. I think often, it very often reinforces the power imbalances that underlie health inequities. It, like I say, often prioritizes the priorities of donors over, where there's this donor-recipient relationship, but it often prioritizes the aid agenda prioritizes the agenda of the donors, and which means that oftentimes the needs and concerns of communities, governments, and civil societies in many countries are just not taken into account, of course. And, you know, I'm sure you all know this, you know, very well. I think, so we know that the aid space is dominated by these powerful interests, and they're the voices at the table. And when civil society and and patients are given a seat at the table, they're regularly tokenized and excluded from these conversations. And we know that, you know, many actors within the sector don't question these underlying issues and premises of the structure of the aid system, because their own ideas often and worldviews have been shaped by and for this industry that it supports. So it's really we should think about the, you know, aid industrial complex as an ideology in itself that we need to try and get outside of. And so perhaps the most damaging thing that happens here is that the benevolence of the aid narrative can tend to obscure the need for much broader structural change. And so, you know, on its own, aid can never lead to a world where each person can live a healthy life. We need to do more than increase aid. We do need to increase aid and increase the quality of aid in the short and medium term to make it, to decolonize it. But ultimately, we need to make sure that we don't just increase the giving, that we stop the taking, we stop the extraction and exploitation that continues to this day. And I think, like, Anand Giridharadas, the author of Winner Takes All, it kind of explains this critique really well, and it's gone really mainstream for critiques of philanthropy, right? But I think we need that same kind of mainstream discourse about this like aid system, because like the things that he says completely apply to kind of global health aid. And so when he says things like, you know, we don't just need to give back, we need to take less. You know, you're not helping a cause isn't a qualification to solving a cause. The opposite is the case. And, you know, we don't just need to do more good, we need to do less harm. So I think that's a way that we need to be thinking about, like, the donors of global health. So, you know, we need to be clear, I think, in our fight for global health equity, that this is an intersectional fight, and that if we're thinking about this is a movement, and it is a critical movement, the movement for the right to health and the movement for access to meds, and all of these things are intersectional fights, and we cannot make serious progress towards health equity without also, you know, a just global economy, without seriously addressing the climate crisis and its mitigating impacts on the global south, without achieving racial justice, gender equity, and the many other interdependent rights, and the advancements of many other different social justice movements. However, though, when you bring this up in global health circles, you'll often be met by actors who will say to you, openly tell you to stay in your lane, or to, you know, don't undermine the progress we've made. You know, stick to the technicalities. Don't focus on this broader stuff. It's a distraction. And I mean, that is just a reflection on where the kind of the global health discourse is, I think. The dominant discourse is, in which there's like the decision makers are very clear in the narrative. The focus is just on the technical solutions, on improving implementation, and celebrating each other for these kind of meager generalized advances. You know, while global inequality actually increases instead of decreasing. So, I mean, that's kind of the deeper kind of narrative that I just wanted to kind of kick off with. And so I think, like, as I said earlier, like, we need to think about this in terms of like, not just giving more, but it's stopping the extraction. And when we're thinking about giving, what kind of giving are we thinking about? And I think when, this is why the reparations debate is so threatening to the aid sector, because it completely upends, or to wealthy governments, because it completely upends the usual narrative of this, like, development is benevolent, which we know that there's many interests at play. So that's a big throat clearing, but I'll get into kind of some ideas and some things that we're trying to work on our partners in health, and what we really mean by kind of stopping the taking. So I just want to lay out kind of the things that we're thinking about. So of course, like, we know that health is like an acute reflection of broader inequalities, and achieving health equity requires international cooperation to address these inequalities. And this means things such as, you know, as a global society, we need to clamp down on this like multinational tax avoidance that's just like extracting money from impoverished countries that have been impoverished by the global north, and putting an end to these like onerous debt repayments that countries in the global south have been you know, being forced on countries. And now they're just paying huge amounts of money in repaying debt that was forced on them, particularly during the structural adjustment period of the 80s. And was a really a direct result of countries gaining independence from colonial powers. And then, of course, you know, there needs to be we need to work to address the tax and antitrust and trade and environmental policies to ensure that there's adequate livelihoods and environmental sustainability for all. These are very big principles, but I think like we have to have these in mind. We have to be moving towards these, because ultimately, like a long-term goal of supporting countries to increase their taxation. So like I guess the thing to say is here, like the answer for how to fund health from wealthy countries is always telling poor countries that you need to increase your domestic resources to fund it. But we know that for many countries, they're already putting in much as they possibly can, but there's still a significant gap for what's required to actually fund, like universal healthcare for all, which is what we need. So ultimately, yeah, we just need to be very aware that I think like the inadequate health, I guess like the inadequate global health resources results in countries being forced to prioritize what's sustainable based on small health budgets, and that's just so unacceptable. And this is because like the status quo is really a direct result of this historical and ongoing exploitation, and that this economic order that exists today consolidated during the colonial period, and it still exists. And that means that actually we think that like money is flowing from wealthy countries to poor countries. The opposite is the case. Actually, it turns out that like the sums of aid dwarf the sums of extraction and illicit financial flows. So actually $2 trillion every year flows from the global south to the global north. 2 trillion. So who's doing the developing and who's the developed country? I mean, this is really just wild. So in terms of getting back to aid and the principles that we really are trying to advance here, I think like we know that during the global COVID-19 pandemic, there's a clear demonstration that health emergencies really know no borders, and we need a global cooperation response to strengthen health systems. And that's really our best approach here to prevent future pandemics and respond to this current one, and also to achieve the right to health. And it turns out that we do have a blueprint for doing this, and the Sustainable Development Goals actually provide this blueprint, and part of them talks about this idea of universal health coverage or universal health care, and there's like clear markers to get to this goal by 2030, which would be a huge achievement. Problem is there's never been global commitments to finance this. So I guess like a big question that we all have on our mind is, how is this going to be financed? And so a big push by Partners in Health is to work to push funders and governments to make sure that their resources flow into supporting universal health care. And the way that can be done, well, I think there's like certain things that we have to see change in terms of right now. Like there's a UN target that was set 15 years ago that should have been achieved, I think 5 years ago, of every country puts in what's called like of their gross national income. They put in 0.7% of the gross national income to official development assistance, and that is like a basic target. And only I think 4 countries have met this target. And so right now, for example, the US is putting in less than 25% of that target. So if all wealthy countries were to meet this target, it would significantly work to close this financing gap for achieving the right to health for all. But we're far from doing that. So we need to really push countries to do this as a key part of like pandemic preparedness, because that's what governments really will be a hook for governments at this particular moment. I think then also like in addition to like increasing this financing gap, there are many other things we need to do to increase the way that money is currently being distributed. So I think like so much money is wasted because it doesn't support locally identified needs and plans. Countries often have really strong national health plans, but very often aid does not support these plans. It goes into parallel inputs with parallel objectives, and doesn't support public institutions, and often is not well coordinated, and just results in incredible wastage that there's really just no need for this. But the reason why this exists is because of course there's many different agendas at play in terms of the donor nations. Then I think next, like we need to, really prioritize support for multilateral mechanisms where possible, and I would love to hear the perspectives of all you on the call on this one. I think just the reason for this is because bilateral aid, oftentimes really important, programs like PEPFAR, but can also, like when it's bilateral aid, it can also undermine kind of the sovereignty and can challenge the donor recipient relationship. I think another key thing here is that funding of global health should not be tied to spending on goods and services. So, for instance, the U.S. government has kind of this approach of tied aid, where it means that basically, I think about 30% of all U.S. federal global health aid is tied. It must be spent on U.S. goods and services, which is really quite outrageous. And then I think like we need to make sure that we're actually introducing objectives that are not just about, they're actually about reducing health inequities, because right now that is not a key objective of most kind of major donor systems. It's maybe an objective could be to reduce poverty, I think sometimes an objective, but there's really never movement away from like this idea of charity towards justice. And ultimately it needs to be about equity. And so, we need to be pushing for these things. I'm gonna stop there because I think that's probably enough for now, but I really wanna, I can't wait to hear kind of people's thoughts and have more discussion on this. But thanks so much for just giving me the time to talk for probably way too long.
Thanks, Joel.
That was great. Thank you, Joel.
Yeah. A lot to kind of like discuss and unpack there. And we'll get to that in the Q&A section. Dazon?
Hey, can y'all hear me okay?
Yes.
Great. All right. Just check in, making sure. So thanks, Joel. That was exactly at the level that I'm not coming in at. So I appreciate that. I'm grateful to be here this evening, and thanks for the invitation, Emily and Jason. I'm constantly in these kinds of conversations and in many different ways. So I'm really grateful to share. For this evening only, I'm just giving you the disclaimer. Dysfunctional is the only way I can describe my day yesterday, because I just could not move. And so all that I wanted to actually put together, I ended up putting together streams of thought instead of due diligence to normal study. I over-research everything. Normal study for this conversation. I first wanted to add to our conversation, though, as we talk about the decolonization and disruption in terms of looking at current global health infrastructure, is that I start with the first question, or what I call the first order of business, which is dismantling white supremacy and patriarchy in the police state. And that's everywhere. We could spend so much time on what's happened just in the United States over the last 400 plus years, and also very recently in the last several years, and even more so in the last few months and in the last several hours, with regard to Breonna Taylor, as well as George Floyd and Brother Prude and so many other people. But I think some of the lesser known stories and the things that we don't talk about is how the actual framework of white supremacy and patriarchy is not just relegated to the West, it's not just relegated to white people, and it's also not just relegated in terms of the fact that it's based on race and gender. And I say that because I raise up the most recent story of including all of our names, the name of Nathaniel Julius, who was a cerebral palsy teenager who was shot by police on his way home from the store. He didn't have Skittles, but he had cookies, or what they call biscuits. And he was shot by a police officer as a mistake, looking like someone else, even though no one looks like Nathaniel. So I just wanted to raise that up before we get into this conversation about decolonizing global health structures, especially in the funding. And so my streams of thought are coming from some of the different ways that folks have been more recently organizing around what this whole decolonization actually means and what we're talking about dismantling or disrupting in terms of that. Money and resources as structural violence is the first thing I think of. Is how are we using money? How are Western and or donor countries, donor agencies, donor institutions using money and resources as a way to wield their own power, to wield their own will, to basically impose what they think is right for others in a very paternalistic and patriarchal way in terms of responding to local epidemics, local issues with health infrastructure, or even how funding is distributed at the local level, who lives, who dies. That's what we're talking about. And that's tied into understanding deeply, and not just those of us who live the experiences, but for everybody who is interested in shifting all of these challenges, moving the direction towards the will, towards the agency, towards the self-determination of people on the ground in communities, living the experiences, and also working towards their own solutions for their own communities. If we're not taking into the context that slavery, redlining, things like environmental racism, the disproportionate impacts of capitalism, and that all of these are underpinnings currently of not just the global health infrastructure, but also how global health response is funded. And that there has to be a new agenda of how we think about the politics inside of all of that, how we repoliticize it, how we change the narrative, how we work towards a discourse that makes sure that the history of where we're coming from and where we are going is relevant to our solutions and our strategies, how we're using that to make the systemic shifts that are needed. And then seizing opportunities that are presented right now by the injustices that have been reinforced by COVID-19 or the novel coronavirus. One of the first things that we did, because it was the first thing I thought about when the initial solution to preventing coronavirus infections or the spread was to lock down, was to shelter in place or to quarantine. And in the work that I do, the first and still the most important thing that we could think about is what's going to happen to women, girls, and children. Because the places where we go sometimes in the day, like work, school, even our faith institutions, are usually those safer places when home isn't safe. And so looking at the opportunity of how we restructure dealing just with gender-based violence or violence against anyone, violence against youth, state-sanctioned violence, as well as community level or individual violence, how we are looking at the opportunities for changing how we respond to those things. And that's coming out, at least in a lot of ways, around dealing more directly with the social, as Joel was saying, the social health determinants, but more importantly, the social and economic needs of communities and how we're addressing those things intersectionally. That the fact that colonialist patterns actually shape the responses to epidemics and pandemics, as well as chronic health challenges, has to be upended. That we begin, I'm not necessarily akin to the idea of bottom up, so to speak, but I do believe that on the ground, outward is what we need to be focused on. It reminds me of Congresswoman Ayanna Pressley, first Black woman to be elected to Congress from the state of Massachusetts, who has a quote that I first heard when she was first elected, and I know that she uses it. It's one of my favorites that applies so much in this instance, which is, the people who are closest to the pain must be the people closest to the power. And what that means is that we have to upend the top-down approaches that usually originate with Western donors in terms of where resources go, what they're meant to do, how they get to where they're supposed to go, and who gets to be in charge of those resources once they are there. And so that also means that we're talking about increasing, defining, redefining, and working really hard to lay out what we mean when we say accountability and that accountability goes in all directions. Another piece that I think about is the different shifts that have to happen. And actually that came through, of course, I wouldn't remember which paper it is now, but that comes through in a bigger conversation about decolonizing global health writ large, in addition to funding. I think that was Buyam and et al. In a British Medical Journal article. And they talk about the shifts that are going to happen to reset, basically reset the entire system, if you will, of global health infrastructure and how it's resourced. One of those, of course, is a paradigm shift. And what I think about that is that the paradigm shift first starts, is just as Joel was talking about, that it starts with a health justice framework. That there are, one of the things I think that HIV, for example, brought into how we've already been disrupting things is that we started focusing in from a human rights perspective or a rights-based approach to health versus the standard or the status quo public health approach or disease prevention approach to global health. So health justice is a framework to consider in terms of shifting the paradigm. Looking at how the donor institutions, governments, agencies are actually looking towards, from a health justice framework, adapting, changing their missions, changing their programs, changing their structures from inside out and backwards, back in. And that means also starting with changing who sits at the tables, who sets the tables, and who gets to reset the table when what's on the table isn't necessarily palatable to those who need those solutions the most. Another area of shifting is leadership. In terms of, and Joel talked about this a bit too, but diversity, equity, inclusion, not my favorite term, but it captures a whole lot of things from a 360-degree level. And that means taking a look at our own selves. I'm a part of an organization, and I'm just saying this because I think that it's huge, that is predominantly organized by and run by Latinx women, mostly cisgender Latinx women. And their overall fight, their main mission is to undo the Hyde Amendment, to just throw the Hyde Amendment away and to have legislation that protects us from ever having some sort of policy that separates out who gets access to services or not. For those who don't know what the Hyde Amendment is, the Hyde Amendment is not a law. It's actually a piece of law that has to come up every single year that's attached to the major appropriations bill. Every time there's a vote on the money that is spent in the United States, regardless of what that's spent on and where it goes, there's an amendment that is attached to it that prohibits completely spending any US tax dollars on abortion access for low income or low wealth and no income women and people who might need abortions. What that says is the inequity in having health access, the inequity in having a right so far, because we know that that's also up for grabs in the current Supreme Court crisis that we have, but that the right to abortion and the health access or having health care for abortion don't matter if only people who have insurance coverage or have means or have money can actually access the abortions. And so a health justice framework says you cannot have that kind of disparity in who gets to have access to this particular protected right or service. And that also extends itself, for example, to the global gag rule, which attaches all US dollars, which again has been proposed to be expanded one more time by the current person occupying 1600 Black Lives Matter Plaza.
Okay.
Yeah, that I wanted everybody to send that miscreant a birthday card back in June to address to the president at 1600 Black Lives Matter, just to give him a bad day. But anyway, the whole idea of attaching laws that prohibit our right to speech, to sharing information, to education, access to healthcare, no matter where we are in the world, simply because it comes attached to a US dollar, has to be done away with. And that begins the process of also eliminating the gender disparities that exist, particularly for women of African descent and women of color. And then there's the knowledge shift. Who drives the discussions? Who decides the solution? Who informs the processes? I am of this next level of where we are as community and civil society, that in terms of what constitutes knowledge in what we're doing nowadays, there's no argument around what clinical science means. There's no argument in what basic and bench science. There's no argument that even because I believe of the challenges that have been presented by community, by civil society, and some really right-minded thinkers who fund the research world, is how do we move lived experience, or what I also call the indigenous expertise of the people who are living closest to the pain, how do we move that up to a level of understanding that that is clear data, that that is powerful data, and that that is science? And that once we can move that to a level of science, then that also means that the resources around what we study and how we come up with the right solutions, the right even drugs and devices to those solutions are actually coming out of the lived experience before they come out of the lab. And then if we talk about disruption, not just as an act, but as a movement across the board. And there was a paper that I also looked at that talked about all the different disruptors in global health structure. And there was a long list of them. I pulled out a couple of them because they're relevant to me and to this topic. But they identified, for example, that HIV and AIDS was a disruptor to global health. And it went into some of these other political terms, but I thought about it in terms of things like the treatment access campaigns that were happening from the late 90s, early 2000s, all the way up to now, in terms of accessing the prevention treatment modalities that we have now. But also intersectional approaches to prevention, treatment, and care. That the disruption in global health from an HIV standpoint also meant that we're not just looking at the disease for disease sake. We're looking at the economies of communities. We're looking at housing. We're looking at gender-based violence. We're looking at the co-infections and also comorbidities. We're looking at some of the other issues, even all the way down to political corruption, all the way through everything that a human shows up with. How that is relevant to the HIV/AIDS paradigm that they're living in is critical. And that is why we have seen a diversification in the funding. It didn't happen initially. It is beginning to shift, and it is beginning to happen. There's even funding for HIV and climate change, because those two things, and environmental racism, and where pollution happens, or where drugs are created and then shipped elsewhere, and then there's all of the remnants and the pollutants that come out of the work that gets done to create those medicines. All of that is a part of what we have been a part of in terms of extending the conversation beyond the disease state of HIV and AIDS. There's also the fact that global partnerships have been disrupted. I can remember, for example, how just bridging the work of AVAC and the Global Campaign for Microbicides moved light years in terms of what kinds of research got funded, who was included in those conversations, how protocol development was happening. And I also would bring in things like Health Gap with ACT UP Paris, with Treatment Action Campaign, and other activist groups working together across the plane, regardless of what might have been happening socially or culturally in our independent countries, that there was common ground and common cause to come together around making sure that wherever people were and were affected by HIV and AIDS, that they were getting what they needed based on the needs that they were expressing, and not what a top-down donor effect was having. The other global partnership that I've seen changing, I'm going to say it's because they're now all being led by Black women. I have not seen the cohesive, collaborative work going on among three of the most important UN agencies to the work that we do than is happening right now under the leadership of Winnebe-Nyima at UNAIDS, under Pumzila at UN Women, and under Natalia Kanem at UNFPA. I think that they are working together and resourcing things that no one had thought about in terms of how these agencies were responding. We're responding to the current challenges that we're facing, including this current COVID crisis and other issues. And then there's research and development as a disruptor itself. A couple of examples that I give to that are the organizing that happened before, during, and after the ECHO trial. There was this whole, that started actually with almost the dismissal of the needs and the concerns of women around contraception and HIV, and that we had as a community to fight. And I know Emily knows this, I know so many of my AVAC partners know this, is that we had to first fight really hard to convince folks that this even needed to be studied further, and that it was primarily the voices of women of African descent, women on the continent of Africa living with HIV, who pushed that initiative. And we worked it from the US side, and there was funding that was made available. And not only that, but there was also, for the first time, a global engagement of community throughout the study in ways that they actually had a lot more power, if you will, that there was a lot more voice, that there was a lot more authority, and that the level of expectations of the researchers were actually lifted. Because you know what, as far as we were concerned, if there wasn't the mobilization that happened, you probably wouldn't have gotten the funding for the study in the first place. So you have to respond to us first. You have to include us in the protocol development and the decision making and in all of the community engagement strategies. Another example I think of that is the fact that implementation science has been advancing, because it wasn't enough to decide what's happening, to learn what's happening in the clinical trial space, but it's also important for us to ramp up the level of engagement we have with understanding what happens on the ground, and community and civil society have been a large part of that. And I've already mentioned the fact that community-based and community-led research and dissemination is the next level, I think, that at some point, I would love to see that community-based research, community-led researchers, and the activism and the advocacy around the research bases, that is elevated to the same level that we look at the roles that clinical research, that basic, that implementation science, that structural research, social and behavioral, that all of those different research modalities, that the community-led research is also as critical to the prolific body of science that we have just around HIV and other health modalities. And then, of course, probably the biggest in terms of disruption as a movement is civil society, rising up and uprising, right? So transforming funding accountability, agency accountability, as flawed and as needy of change as the whole PEPFAR enterprise is, it is light years from where it was even 7-10 years ago in terms of community accountability, as well as the meaningful engagement of community in the overall process on the ground. And that there are new models of working with governments and industry and other donor groups. Recently, as a result of the COVID crisis, the reproductive justice movement that we're a part of wrote an open letter to the funders who all the funders, they always meet together, wrote a pretty intense letter saying, here's what we need to survive this in this moment. And the way that some of those funders have responded is something that they will not be able to undo for many, many years to come. And I could go through that list, but it was an exhaustive list of things that funders needed to reconsider how we use and how our relationship with the donors are now and what they need to be in order for us to deal most effectively with this extended coronavirus crisis. And of course, there's the ownership of global initiatives. Joel has already mentioned Sustainable Development Goals that are the next iteration of the Millennium Development Goals, which were also adopted and promoted by community. But there's also things like moving from treatment as prevention to U equals U. That was a disruptor in and of itself. And what I call right now, and I'm going to leave this just up for conversation later, is IAS versus everyone else. Okay, so I have a few questions that I just want to leave on the table because I know that you're going to be in some individual or some really cool, intimate discussion groups over the next several Fridays. I've got 4, and I'm going to share all of these with Jason and Emily once we're done. 1, does ending white supremacy and patriarchy end neocolonial funding structures by default? How about this one? Insider, outsider, both. Disrupting donor organizations, whether government, private, family, individual, corporate, which way works? How about maybe, does the diminishing political economic positioning of the West offer opportunity for greater disruption or not? For example, do we now have a bigger threat from the East? Who knows? And then my last question was centering itself. So centering as a core strategy for disruption, centering Blackness in our work, centering people living with HIV, centering gender and nonconformity, centering justice. What else could you think of that as we plan and move forward in shifting and upending and changing things for a long future, as well as thinking the long game, is what else should we be centering in our movement work so that we are effectively changing how global health funding works to solve our biggest problems? That's it.
That's it. Thank you, Dazon.
Can you say something?
Appreciate you.
Thank you.
Who had?
So,
Sorry, go ahead, Jason.
yeah, so thank you.
Excuse me.
Want to kind of like open it up to the folks who are on the Zoom, like for folks who have any kind of like clarifying questions. There was a lot of questions that Joel and Dazon kind of like proposed to us. So just wanted to open up if folks have any questions or even just even comment to this. Yeah, so just want to open it up to folks. Feel free to use the chat or just unmute yourself if folks have any type of comments.
Well, since no one's rushing, I did have one clarification. I'm OC, by the way. I was unclear after everyone had mentioned the problems and the issues that stand in Health Gap's way. I was unclear about what it is you intend to do about it, what we can do about it. And if you said that already, I apologize, but I was a little unclear. That's it.
Well, part of, so we did not, I don't think anyone has said like what we're gonna do about it, right? I think that both Dazon and Joel have laid out a lot of the problems that we see with global health funding. And I think that part of the goal that Jason and I have with this, with talking with you all, is that there are a lot of solutions to the problems that we see, and we don't have, like, we can't do it on our own, right? So it's up to all of us together to decide what we want to tackle and what issue we say, like, that's the thing that I care most about, and we need to figure out who's responsible for that thing and what are we going to do together to fix that problem. So I think that is, yeah, I'll just say we don't have all the answers yet. We want to do that together.
Okay, thank you. So in other words, it's not a huge concrete wall of a problem. It's more like brickwork. And each of those bricks has their own sets of tasks, schedules, and solutions, right? That's what I'm hearing you say. Is that
Exactly.
a fair statement of what you said?
Mm-hmm. Yep. That's the way I see it.
Yeah, and on Tuesday, Emily Bass spoke to this exact point about how the issues are big and overarching, but then you have to sort of like distill down what and how you're going to attack a part of the problem to get your way in, to put your crowbar in the crack, as we like to say in Health Gap.
Well, what I do want to say that I think I did bring up, though, is some of the things that, because all of this has been more evolutionary, right? So there have been moments and times and milestones in our own history where we know what we've done, where we knew what it took and have gained. But it's sort of like when you're running really fast, but it's still moving faster. I almost feel like my cousin, as I used to say, I feel like sometimes the work that we do is like the rims on his car, right? That we're spinning while in motion. So it's sort of like you're constantly working on something, but everything is still moving forward. And so it's oftentimes hard to stop in that moment and capture all of the pieces. The other thing, though, is that we are intentionally, well, we're not intentionally making our lives harder, but because the situations are complicated, there's no way to simplify them. There's no way to break them down. People live intersectional lives, which means we need to have intersectional solutions. And by bringing intersectionality in as a framework by itself adds multiple layers of complications, right? And so that has to be unpacked so that we can fold it up and pack it properly in the context of the different strategies or the different movements that we need to tackle some of the bigger issues across the board. I also think that it is really, really important for us to begin to show the shift around what happens when you do engage people who are living the closest to the pain. And I don't think that we collect that enough. I don't think we tell those stories enough. I don't think that we put the science behind that enough. I don't think that we I had a conversation just today with someone about recognizing my own privilege, right? And that's interesting because I'm a Black woman from a small town in Georgia. However, when I talk about the privilege I have in my work, I was born in a small Black college town. So by being in a Black college town, that means a lot of the Black people that I know are actually educators. They work on a campus, or they're a part of the local military base, that there's a different level of power and engagement that the Black people in my town have versus Black people in a town down the road in southern Georgia, where there's very little power and very little representation. And then I go to a Black college, and then I'm in a Black city, and then I run a Black women's organization. And there are so many people that I don't even take into account daily that don't have that privilege of being able to address our issues with each other on a constant basis all the time, where some of these solutions that look really, really hard to other people just totally make sense to us. And that's because they're working in really different spaces where they might be one among 100 people, and they're the only Black person working in that department or in that division or in that organization or on that college campus or in that town. And so I really think it's important for us to sort of dial back and sit with ourselves around how our own privilege shows up in our work, and how we either make sure that that privilege too is being used in a way that advances everybody in an equitable way, or we check that privilege and we step back, we sit down, and we follow the leadership of someone who's actually closer to the experience that we're trying to address.
I saw a question that was posted. This one comes from Grace Kim, and the question is, how can donors' movement towards localization be leveraged to be a disruption to the current funding structures? So how can donors' movement towards localization be leveraged to help disrupt the current structures?
You know, the first thing I would ask is that donor funding restricted or general? I think at some point we need to just say, fuck the restrictions. Because what you wrap around what you think is the solution to my problem, and you haven't even taken the time to, you might ask the people who, have been studying me, but you didn't ask me about what those solutions might be. But you want to trust my organization. So trust my organization. And when I say this is what we need and what we want to do, then you say, you know what? We like who you are. We like what you're doing. Go for it and be productive and be solution oriented. And that should be it. That's one of the biggest things, I think, that in and of itself changes the paradigm at the community level. And I mean that in this way. You might want me to get more people on PrEP. And that's what you're going to send me my money for. You want me to make sure that more people in a low resource community with not as much information about pre-exposure prophylaxis, that you want to make sure they get that. Well, I'm in a community, for example, where the county health department or the governmental health department is not making that available, right? Not only are they not making that available, but they're not including us when they deal with the budgets of the funding that's meant to deal with HIV prevention. So instead of you sending me the money and think that I'm getting ready to go out and convince people to take PrEP, I'm going to take your money and stage some major work working with the government to shift how they're dealing with my community. Then we can work on how to get people PrEP, because the government now understands from our perspective what should be happening so that people can access that. That's not small, but it's not simple, but it is a small thing to think about the big impacts that something like that could have. It's just by saying, and this is actually what we've been able to do with a lot of, I don't know about some of you who might actually have donor relationships during the COVID crisis, but that is a lot of what some of our funders have done, is they've even shifted our current contracts to say, why don't you just use this to get through the crisis? You can use it for however you need to use it, and just tell us what you did. I think that's fair.
Does anyone-
Sorry, go ahead, Jay. No, go ahead.
No.
I was just going to acknowledge that we are at time, but there was a question about, would you address molecular HIV surveillance? Don't know if that's a quick one.
I don't even know what that
Joel,
means.
you got that one? Huh?
I don't even know what that means.
I kind of answer that one.
Okay, so, and anybody else, please help me. I know Emily is out there somewhere. So, so essentially what it is, and I don't have all of the language either, but molecular surveillance is basically contact tracing the genetics of the virus. That's the best way I can say that. So, for example, you know, we've learned over time that people living with HIV, they have certain strains, and that when when someone is actually exposed and then contracts HIV, that they are going to have similar strains of the virus from whomever had the virus that they contracted it from. And so the surveillance system is being used as a way to trace that virus. And that's and it is considered surveillance because it's the way that we're able to find out where clusters are. It's a way to find out where certain treatments are going and why they're going in certain communities. But what is also really, really important is that it is people's DNA, it's people's blood that is in a database, that is in a system that a government is using to track the virus. And we're not feeling safe around that. There are already ways that in the United States, we know that there's risks for molecular surveillance being used in terms of people who are not documented and are living with HIV in the United States. It's a way to find them and then to treat them inequitably. It is a way to actually, I'll give you an example of what I heard from Croy. I'm going to say it was maybe 2013, if that was I know it was in Boston, so it was a Boston Croy, where the CDC was originally talking about the fact that by using this molecular surveillance, that they had been able to distinguish the amount of HIV that was transmitted to, particularly to Black women, by men who were having sex with men and women, right? And they didn't release that. They didn't have an intervention for that. They didn't have a messaging for that. And when we queried about, well, you know, the whole issue around disrupting, if you will, the discrimination and the stigma of bisexuality, or the stigmas of people who have sex with men at what I call MSMW ADTs, men who have sex with men and women and don't tell, that we didn't have the social and cultural structure to deal with that without making things worse. And the CDC didn't have an answer for that, so they just sat on it. They just sat on it. But now we know, because they've just released all of this new data, that an expectation that a large reason for the reduction in new HIV incidents in women in this country is because they're having less sex with people who have sex with men and women. For real though? For real though? How y'all know that? And how are we supposed to know that? And why aren't we in conversations about how you know that? And then what are we supposed to do with that once you tell us that, right? So that's what is problematic about molecular surveillance, as well as we have obvious judicial systems that, despite the fact that we have U equals U and treatment as prevention, molecular surveillance is also a tool that can be used to further criminalize people living with HIV. So I don't want people to get it twisted that there's an answer to this, because the science has a purpose, but that purpose could also be very dangerous to people living with HIV.
We have one, can we take one more question? Desmonio, I hope I'm pronouncing your name right, asks, can a conversation like this piss off people in power people in power who are in control of funds? How can we step out to change this? I would say, so like, go ahead, yeah.
So the answer is yes. And it can, and it has. And what we've also learned is that we actually use, and I don't want to use that terminology, but you use sort of that bait and switch kind of, well, the terminology that we know most in American colloquialism is the good cop, bad cop. So you have to have a pairing, if you will, of the tolerable voice that doesn't sell us out, but is the tolerable voice. And then there are those of us who are not necessarily tolerable to some of those funders, right? So that's some of the strategies that we have learned that we have to deal with. In my experience, especially in the reproductive justice world, Black women, we can't raise it. We cannot address these issues with funders. We can't call them in. We can't call them out, right? So even most recently, where because of Black Lives Matter, because of the Black RJ issue, because of the maternal mortality rates among Black women in this country, because of HIV and gender-based violence and all of that other stuff, right? That they went to a funders meeting, the Black women laid out all of the issues, but it was the Latinx sisters who laid down the ask. You understand what I'm saying? Because they were less of a threat. And that's a strategy that we have started using, is really finding the way that we partner up with what makes them get to yes. And then we still do what we need to do, because at the end of the day, we're still all in solidarity. We just show up differently and they react to us differently. And so we understand that. And we're okay with using that for now, because we're also about building solidarity. And we're also about helping our sisters understand that centering Blackness is what gets us all to the way.
Yep. Cool. Thank you so much, Dazon. Yeah, very powerful.
Exactly, Emily, thank you. Exactly, that's why I didn't want to use the phraseology.
But it got us to where we needed to be, so that's what counts for now.
Cool, Em, you want to close this out?
Sure. So on Tuesday, this is selfish, but on Tuesday, we ended the call with asking people to share one word about what they're taking away from this session, either like how you're feeling or what you're leaving with, or what something that clicked for you during this. And I loved reading that last time, so I want to do it again. So if everyone could leave one word in the chat box about what you're taking away or how you're feeling or something that clicked for you, please do that. Yeah, and just a plug again for there are so many big topics that came up today, and we could have a whole another 3-hour conversation about only what came up today, right, between Joel and Dazon. And I feel like it was the same sort of feeling on Tuesday. So if you want to talk more about this stuff, tomorrow at 12 Eastern time and 3 p.m. Eastern time, Jason and I are going to be available for an hour to talk about all of this and whatever. It won't be a very structured conversation. It'll just be whoever shows up will talk together. So please, like, definitely encourage you to show up for that, and I'll resend the link and a reminder for that in the morning. So please, yeah, I would love to talk more with you.
I can read some.
Yeah.
Solidarity. Shout out was given. Thank you, Dazon and Joel. Very informative and thought provoking. Someone loves the Ayanna Pressley quote. We have ignited, empowered, action. This isn't one word, but donor institutions and donor government need to release the restrictions and say, do with the funding what you need to do. Someone says re-inspired again. Justice exclamation mark. Also, thank you, Dazon and Joel, for such a great lesson. Illuminated. Thank you all. Encouraged, motivated, not alone.
Thanks, Citra.
Transformative. I'm taking home centering people living with HIV, especially KP populations.
Yes.
It's KP.
KP is key population.
Oh, key population. Key populations in my context. Otherwise, thank you. Good night. Battle ready.
I love that.
Yeah, battle ready. And thank you.
Borderless. I love that one.
Thank
Say
you,
her
Emily.
name.
Awesome. Okay, thank you all. Have a good, safe evening, and talk to you either tomorrow or Tuesday.
Yep.
All right.
There you go.
Thank you so much.
Thank you so much.
Thank you so much.
Thank you all. Thanks for listening and being here.